Thank you very much, Professor Shamim. Assalamualaikum and welcome back. I will try to keep my talks short in the interest of time. And once again, I have to say that it has been a pleasure to be here. And not only can I share my experience, I can also hear from the other speakers and update my knowledge at the same time. So I'm giving back-to-back talks. The first one is bronchothermoplasty, basics and indication. It is the objectives from overview to recent advances in bronchothermoplasty or BT for severe asthma. So we'll start with a difficult asthma case. I had a case referred 6 years ago, a 27-year-old female asthmatic since the age of 14 from a northern state in Malaysia, frequent admissions and ER visits, life-threatening asthma, 4 intubations, on maximum medical therapy already, even taking oral prednisolone, and she became Cushingoid, and she was referred in 2013 for bronchothermoplasty, and let's see what happened to this patient. So the concept of targeting the airway smooth muscle for asthma therapy is somewhere in the mid-1990s when somebody came up with this suggestion that if we could do something to the airway smooth muscle in asthmatic, perhaps we could treat asthma. But we also know that the airway smooth muscle is not a mechanical bystander in the airway. Then it is felt that the airway smooth muscle also plays a role in bronchoconstriction, hyperresponsiveness, inflammation, and remodeling and interaction with epithelium and nerves, leading to asthmatic attack. So, and we are familiar with the concept of airway remodeling in someone with normal airway compared to somebody with asthma, especially in chronic asthmatics. And you have hypertrophy and hyperplasia of the airway smooth muscle. So what is bronchothermoplasty or BT? It is a novel non-pharmacological therapy. Basically we use a radiofrequency energy to the airways, and it is basically a debulking procedure. So the word debulking is not just confined to tumor management. We do debulking of tumors, but it also applies to bronchothermoplasty. So based on one study, it was this technique BT was FDA approved in 2010 for treatment of severe persistent asthma. And basically, when it was approved 8 or 9 years ago, it was indicated for asthmatics who were inadequately controlled despite treatment with ICS and LABA. And before I forget, I must also say that here, even in India, BT is already available. At least I know one center in Hyderabad. Dr. Hari Kishan is doing it. But anyway, when you have a case of uncontrolled asthmatic or difficult asthmatic, it is not a knee-jerk reaction. So you straight away you refer for BT. No, basically I think the most important question is this really asthma? Actually, in that case referred to you, is it really asthma? And I had cases referred to me for BT, and which turned out to be emphysema, COPD, and lung fibrosis, bronchiectasis. So we have to be sure, we have to review the diagnosis and all other aspects which you are very familiar with, managing comorbidities, education, compliance to treatment. Is the patient has the patient been optimized in terms of management, the techniques, inhaler techniques, environmental and occupational triggers. All these have to be addressed first before you refer your patient for BT. And this is the BT system. You have a base, a unit that generates the energy, and then this catheter, LA catheter, the proximal end and the distal end. Basically, when you trigger the proximal end there, it will expand the electrode, the 4 electrode there, which will come in contact with the airway smooth muscle, and then you will deliver the thermal energy to the airway wall. So the technique, the procedure itself is not difficult. I think Dr. Harry agreed with me that it is a very boring procedure actually. Okay, because basically you just place the catheter inside the airway there and deliver the energy, and like this. So it's not difficult. And at the end of the procedure, my hands become numb actually, because spending about half an hour just to do a BT. So it's not difficult technically. So one of the early studies, proof of concept. So this study was done on dogs. Some dogs were not treated, some dogs received BT, and then basically they showed that in dogs' lungs treated with BT, there was reduction in the airway smooth muscle. So that's the idea, the original idea about this technique. And then after the trial on dogs, that led to 3 human trials. A small number of subjects. You have the first one was performed by Dr. Cox and his group, and then after that followed by the air trial and then RISA trial, and then there was improvement in all these 3 studies, and there was improvement in symptoms, the reduction in mild exacerbation, improvement in asthma quality of life, and in terms of the rescue medication as well. And even in the RISA trial, they enrolled patients with severe refractory asthma, severe refractory asthmatics, the sort of patient we would like to offer this technique. And there was improvement even in FEV1 in severe refractory asthma. After that, there was this Air2 trial which led to the FDA approval. So a quite interesting trial, 2-to-1 randomization. One group received BT, the other group received sham BT. Basically, the patient underwent bronchoscopy, and then the operator would deliver a catheter into the airway wall, but no energy was delivered to the airway wall. So that's sham group. And they carefully selected the patients. Only those with FEV1 of more than 60% of predicted were included in the study, and they had to be stable for at least 1 month before entry. And they excluded life-threatening asthma and history of 3 or more hospitalizations for asthma in the previous year. And the findings, this study, this Air2 trial received criticism because, as you can see, that the primary endpoint there, asthma quality of life, 79% of BT patients achieved the significant improvement in AQ-LQ, but 64% of the sham subjects also received significant improvement in AQ-LQ. So it was widely criticized, so I think the argument will never end. I don't know how to explain the placebo effect in the sham subject there. But when you look at the secondary endpoint, okay, although 6% of the BT subjects were hospitalized. So this is not surprising, obviously, when you do a procedure, especially bronchoscopy in the airway, in asthmatics, even flexible bronchoscopy, there will be worsening of asthma symptoms. So it's the same thing here with BT. So 6% of them were admitted for a worsening asthma symptom. But the secondary endpoint there, as you can see here, the BT group had fewer severe exacerbation, 32%, and emergency room visit as well, 84%. Okay, and again, some people were not happy. How come you only got good secondary endpoints, but not the primary endpoint? So you'll never end the argument there. Okay, and then since the A2 trial was criticized because it was only for 1 year, so they decided to follow up this patient for up to 5 years. So it's called A2 extension study. So those patients who underwent BT in the A2 trial were followed up annually for 5 years, and then these were the outcomes that were assessed: severe exacerbation, adverse events, and high resolution CT scan to look for any structural changes in the airway. Again, the A2 extension study was criticized again because there was no follow-up for the sham subject. And then you see that the retention rate is very good in the A2 extension study. They're up to at 5 years. Almost 90% of the subjects managed to be follow up in the A2 extension study. And just to summarize the finding in the A2 extension study, you can see that the effect of BT was sustained for up to 5 years. This is before BT, and then the first year, second, third, fourth, and fifth year. So the effect is sustained for at least 5 years in terms of reduction in severe exacerbation and reduction in ER visit. Okay, so what else is new then? Okay, so just to share with you one study that was published 4 years ago about smooth muscle and BT. So basically, the study shows that whatever the percentage of smooth muscle that you have at the beginning, you will get the same amount of reduction in airway smooth muscle after bronchial thermoplasty. And it's the same thing here. Not only do you get reduction in airway smooth muscle, you also get reduction in the basement membrane thickness post bronchial thermoplasty. Okay, what about real life studies? These were not randomized control studies, and some of these were case reports and case series, but all these studies showed there was improvement in AQ-LQ and severe exacerbation after BT, and I think there was one study from Australia that showed that the number of activations had a role in responsiveness. And as you can imagine, in the A2 trial, you remember about 6% of the BT subject developed worsening of asthma symptoms and were hospitalized. But because in these real life studies, there were many very severe asthmatics, so it's no surprise that a higher percentage of these patients required emergency readmission or stay after the procedure, 11 to 22%, because these were more severe asthmatics. And what about post-approval study? This was ordered by FDA, I think. And as you can see here, the findings in the post-approval study, PAS2, more or less the same as the findings in the A2 trial there. It's consistent. Similar improvements were seen in severe exacerbation and ER visit in a post-approval study there. And then again, some people are worried what would happen to the lung function after bronchoplasty. Basically, in the post-approval study, it shows that there is no significant reduction in lung function. So what do we know now? Just to summarize, in adult patients with moderate to severe asthma, BT is associated with all the improvement, reduction in the frequency of asthma exacerbation, reduction in days lost from school or work, improvement in AQ, LQ, and reduction in medication needs. And these effects appear to be sustained for at least 5 years, if not more. Okay, and BT is associated with short-term increase in asthma-related symptoms in the immediate post-procedure period, and BT appears to be safe at least at 5 years of follow-up. So certain things we still don't know the exact mechanism, the pathway. As I mentioned earlier, although we target the smooth airway, but the smooth airway muscle, but the airway smooth muscle is not a mechanical bystander. So we don't really know what if there is anything beyond airway smooth muscle in BT. And then predictors of response in this era of personalized medicine. I think we are still waiting for result of ongoing studies to see if we can predict which patient will respond to BT. And then what about the long-term effect, more than 5 years? I don't know what to say, because even at 1 year, the Air2 trial showed improvement at 1 year, people were not happy. And then they did the Air2 extension study, up to 5 years, it shows sustained result. Still people are not happy, okay? And they want to know what happened beyond 5 years. I don't know, it will go on and on. After 10 years, if there is improvement, they want to know what happened in 20 years' time. It looks like it will never end, actually. Okay, so, and then we don't know because you remember the Air2 trial excluded patients with poor lung function, so we don't know patient on high, what happened to those, whether we can offer BT in patients on high dose maintenance oral steroid, those with very poor lung function, those very frequent life-threatening asthma. We don't know. Okay, sorry. So quickly going, who is a good candidate for BT? The current guideline there, I think you can easily Google this. Basically, all support BT as a therapeutic option for patients with severe asthma. Although Gina, stated that patients with FEV1 of less than 60% were excluded in the Air2 trial. Okay, and same thing here. ATS, in fact, recommended that this technique should be performed as part of a registry, actually. And BTS as well. Okay, still some doubt there, although the place in the treatment of asthma remains to be established. What about the Malaysian CPG? We say it is a treatment option in severe asthma. But the use of this modality is to be decided by pulmonologists, and in my personal opinion, I think this will be the ideal patient, frequent exacerbator despite maximum therapy, and not a candidate or non-responsive to biologics. Those type 2 low severe asthma, non-eosinophilic, non-allergic asthma. Future direction, I think we have some data from bronchoplasty global registry, and I think this is the one that we are waiting for. Bronchoplasty 10+ years study. What happened? In those patients in the AIR, RISA, and Air2 trial, and even the sham and control patients were invited to participate. Because there was a lot of criticism why in the Air2 extension study the sham subject were not follow up. Okay, so I think we are waiting for the finding from this study, bronchoplasty 10+ year study. I can share with you this bronchoplasty global registry, the top one there, the findings. This was presented in CHEST last year. Basically, it shows a consistent finding that BT, there is improvement in terms of severe exacerbation, ER visit, hospitalization, even the use of oral corticosteroid in patients who receive bronchothermoplasty. So back to our patient post BT. Well, she completed the 3 sessions, and it took her about 3 to 4 months before she could feel the improvement after BT. So, initially she was worried whether BT worked or not, and she even asked me, in the first one or 2 months, she was still, not stable enough, But after 3 or 4 months, there was improvement, and then so we managed to cut down her medication, and she was off her oral steroid, and finally she got pregnant. And fortunately, her asthma was stable during her pregnancy. She only had 1 attack in her first trimester, and she gave birth to twins. And that was a happy ending story. Okay. But not everything is good. Okay. Okay. So so I even in my place I do get non-responders. So this is one of the case reports showing failure of bronchothermoplasty in severe persistent asthma. So I think in the AIR2 trial, the success rate was about 80%. So even in the AIR2 trial, there were non-responders. So, and not everybody respond to this, and that's why I think we need to wait for the result of the ongoing studies, whether we can predict who will respond to BT. Okay, finally, the last slide. So to me, BT is an alternative therapy for patients with severe asthma that is not well controlled despite on high dose inhaled steroid and LABA. And there is histological evidence that BT reduces smooth muscle mass. You saw the evidence there. But I think we are still waiting for the ongoing registry, such as the 10+ year study there, so that it will give us more information and to clarify the role of BT in severe asthma. And then again, in this era of personalized therapy, precision medicine, we need additional studies or wait for the result of the current studies to establish the accurate phenotyping of positive responders. Thank you very much. That's my first talk on BT. Any question, or I'll go to the second talk.
Just one question. Is there any role of BT in ACOS, asthma, COPD overlap?
I don't have, there's no data on this yet, but we never know in the future the role of BT in ACOS.
And in severe asthma who have had some kind of remodeling in the airways, is there any role in severe asthma, those patients who already have some sort of remodeling in the airways?
Yes, definitely. I mean, remodeling is really associated with hypertrophy and hyperplasia of airway smooth muscle. So definitely in asthmatics, especially in chronic asthmatics, they get airway remodeling. There is a role for BT, and that's the target. BT, the target in BT, that is to debulk the airway smooth muscle, to reduce the airway smooth muscle mass. You have hyperplasia and hypertrophy, and that's the target in bronchothermoplasty. So I've already explained this, and basically we deliver controlled thermal energy to the airway wall during a series of 3 sessions, 3 bronchoscopies, and we treat every visible airway that is more than equal or more than 3 mm in diameter. Basically, the technique reduces the airway smooth muscle. It is a debulking technique and reduces the ability to bronchoconstrict. and reduces the frequency and severity of asthma symptoms. It was FDA approved in April 2010, and it is widely used in many countries all over the world, including India. And this is the evidence that BT works. In a canine model, you see that when we perform metacholine challenge test, in this model, the left side was treated with bronchothermoplasty, the right side was not treated, and see what happened there. The untreated airway developed bronchospasm. Okay, and the treated airway did not develop bronchospasm. So I think that's the rationale for offering bronchothermoplasty in asthma. And so this is the unit here, as I mentioned earlier, the BT unit, which delivers radio frequency energy or thermal energy to the airway wall, and then this is the LA catheter, it's a flexible tube with an expandable wire array at the tip there. We will come in contact with the airway wall, and basically we deliver the thermal energy at 65 degrees Celsius for 10 seconds. And the system, the unit here, has multiple safety algorithms to ensure control energy delivery. So it won't deliver more than 10 seconds. And so these are the procedure details. The patient is stable for bronchoscopy. So the first session, we treat the right lower lobe, and then hopefully the patient will recover after 3 weeks, sometimes up to 4 weeks. Then we treat the left lower lobe, and then 3 weeks later, hopefully we can treat the both upper lobe, which is technically the more challenging part, especially going to the apical segment of upper lobes. And sometimes, to be honest, I also had difficulty to reach the apical segments. It is quite challenging actually. And before I forget, I think Dr. Umul mentioned about one case, one incident of severe bleeding in the Air2 trial, not mentioned anywhere. I didn't know about it until today. The thing about the catheter there, I noticed from my experience, you cannot force the catheter. When I try to force, I would cause trauma, and then that will lead to bleeding actually. So you do not force. And sometimes the depth, the airway there is not deep enough for you to deliver 4 activations. Sometimes I end up delivering only 2 or 3 activations. You don't force. When you force the catheter, then you cause trauma and bleeding. All right, so you can do the procedure either in the bronchoscopy suite under conscious sedations if you are comfortable with it, or in the OR under general anesthesia via endotracheal tube, not via rigid bronchoscopy, okay? And then prednisolone to stabilize the asthma, and standard sedation and monitoring. So there's nothing here that is different. And depending on your practice, basically, I mean, for me, I do BT under general anesthesia routinely via endotracheal tube. There was one case when I noticed the patient developed bronchospasm when I wanted to treat the right lower lobe. It's supposed to be the first session. The airway just collapsed actually. Yeah. So I had to do the first session on the left lower lobe actually. So just imagine, the possibilities, when you try to do it under conscious sedation. And the papers, especially from US, I think they all say that it can be done under conscious sedation. Fine if you're comfortable with it, but I heard, my colleague from Singapore who did this procedure, one patient developed bronchospasm on the table as well. So to be on the safe side, I think it is comfortable to both the patient and the operator if you do it under general anesthesia. And okay, so I'll show you the video of the technique. There's nothing too difficult. So this patient was intubated, and we did the procedure by endotracheal tube, and then the catheter is inserted through the working channel of a flexible bronchoscope. These are my two fellows, and we just deliver the energy to all visible airways. I think, as I say, after 10 minutes you get really tired, and your fingers become numb actually. So you try to deliver, you give the energy distally, and then you pull out the black mark to guide you when to stop actually. So it's very easy. Okay, and you are supposed to to deliver 4 activation in each subsegment, and you avoid pushing the catheter. If because you want to try to deliver more, that will cause trauma actually, in my experience. Okay, so again, you try to deliver 4 activations in a subsegment. So approximately 60 activation per procedure. I don't always get 60 activation per procedure. I suspect because my patients are smaller, the Asian population. So I think in India, if you want to know how it is done, you can go to Hyderabad. Okay. So it's quite simple, and it is a boring procedure actually. Right. So this is the 4th activation, right? The orifice of that particular subsegment there. Okay, and this is a procedure map which I find it very useful. Our assistant can document where we deliver the thermal energy. And as I said, you start from distal, and you gradually bring the catheter proximally. And okay, just to show you before and after. So this is before in the left lower lobe during treatment. This is what we do, and then after treatment, basically you see some, basically the airway mucosa that becomes inflamed, bit reddish, and maybe there is a blanching of the airway mucosa. That's all. So we don't burn the airway. I mean, the critics would love to use the word burn, I think, Okay, we are burning the airway. When we do BT, we burn the airway, But as you can see that there is no charring, noted. Unlike when you deliver laser or APC, you see charring, but you don't see any fire there, But critics love to use the word burn, burn the airway, I don't know. There are always people who love to criticize this technique. Okay. So post-procedure and patient follow-up, standard really, patient will be monitored for a few 2 to 4 hours post-procedure, and can be discharged from the hospital the same day. I don't do this, it depends on the patient condition. And so the lung function is stable within 80% of pre-procedure FEV1. You can discharge the patient, okay, and you give oral steroid up to 5 days. That's my practice when they are discharged. And then you can contact the patient. You can ask your nurse to contact the patient to see if the patient is stable, and then you arrange for the next session, the second session and third session. Okay. And then but eventually, if the patient is stable, the patient can be discharged and sent back to the primary care physician for long-term asthma management following BT. Precautions, you don't offer BT, you have to postpone the procedure if the patient is having an active respiratory infection, not stable, the asthma is not stable for the last 2 weeks, there is a known bleeding disorder, and if you are unable to stop anticoagulants, antiplatelet agent, and non-steroidal. Contraindications, these are the contraindications. You don't offer this procedure in patient on pacemaker, internal fibrillator, defibrillator, or other implantable electronic device. And this is, I think, it's a relative contraindication. Previously we were told that we shouldn't offer this procedure in someone who had received a BT in the past. But I heard that there are people, who still offer this, after 5 years, the asthma was stable, and then the asthma became uncontrolled. Some centers would offer a second BT actually, although it's not documented anywhere in any journal or papers actually. Okay, now the last few slides, FAQs, frequently asked questions. I just want to share with you what was presented in CHEST last year. The 3 questions here: does bronchodilator responsiveness matter? Is the number of activation important? Should we treat the right middle lobe? That's a $1 million question, I think. The right middle lobe. Okay, let's see. The first question, bronchodilator responsiveness, does it matter? No. Okay, so in this study published in Respirology, group 1 with reversibility, group 2 fixed airway obstruction, no different. Okay, so no influence in terms of outcome. Okay, next question, number of activation. Again, is in this study, patient with more activation had better asthma control. Although in my practice, I don't always see this. And then they also found that FEV1 dropped transiently by 9 to 15% after the procedure. So this could be an issue if you do the procedure under general anesthesia. If you inform your anesthetist, the FEV1 is what 30% of predicted, and then you tell your anesthetist, FEV1 may drop, by 9 to 15%, then you have problem to convince your anesthetist to do the procedure under general anesthesia. Okay, and the $1 million question: should I treat the right middle lobe? Again, there's okay. There are no data yet, but again, I've seen some centers performing BT in the right middle lobe. I think previously there was concern whether treating BT, giving BT in the middle lobe, right middle lobe, would cause right middle lobe syndrome. But I don't see, I haven't come across any evidence for that. But there are centers that treat right middle lobe actually, and I personally have yet to treat right middle lobe. I don't know, Dr. Harry, are you treating the right middle lobe? So I have just received a referral for BT 1 month ago, and I might consider treating the right middle lobe. Then she might be my first patient to receive therapy in the right middle lobe. Okay, what about Malaysian Experience? We started the procedure 7 years ago, and then we managed to publish the first 3 cases at the World Congress of Bronchology in Kyoto in 2014, And then recently we have done about 21 cases, not many. We analyzed the data. We noted that even with lower activation, you could get good response. And my team is going to present our paper in Chess Bangkok next month. I think some of you may be going there. So I'm not going to reveal the findings. So if you want to know the finding, you have to go to Bangkok. Okay. All right. I think this is my second last slide. That Darth Vader there. I think if BT can turn Darth Vader away from the dark side, I think BT is good. Okay, that's my hospital, and that's Putrajaya, the Federal Administrative Center of Malaysia. Thank you very much.
Any questions? Dr. Jamal, what do you think will be the effect of beta-2 agonist and steroid after BT?
The effect of beta-2 agonist after BT?
After BT, yeah. There will be any change in the response before BT and after BT?
I don't know. You mean the reversibility, is it? I don't know. I haven't tried that before, actually. But one of the slides that I showed, there's no difference in the group whether they had reversibility or no reversibility. But the bronchodilator response post BT, I don't know, because I never checked myself.
Dr. Jamal, very educative session. How do you discharge these patients? Like, do you routinely do a spirometry on the same day after procedure?
Practical question. Obviously, during immediately post-procedure, the patient is very unstable to perform spirometry. So I don't discharge the patient on the same day. So the patient will be kept in the ward for 1 or 2 days, and clinically, if the patient is stable, then I'll perform spirometry, and if it is 80% of the pre-procedure FE1, then I'll discharge the patient. But some patient may not be able to perform properly, and then so you go by clinical and time. Lungs are clear, good entry, despite FE1 less than 80% of the pre-procedure BT pre-procedure, I will still discharge the patient and close follow-up, I think.
Risk of developing bronchiectasis?
Bronchiectasis, I'm not aware.
Means we are delivering the energy and we are as such decreasing the mass of the smooth muscles, and we are leading to dilatation of the airways as such. Any impact of retention of secretions or anything? Ultimately leading to bronchiectasis or anything?
I guess we have to see the global, the 10+ year study and see what happened, I think during BT we don't really dilate the airway. We only deliver thermal energy to reduce the airway smooth muscle. We do not dilate the airway. And I think that the post-approval study also showed the lung function remains stable actually up to 3 years post-BT.
In one of the trial, AR2 trial, one patient developed bronchiectasis. 3% now.
It's not mentioned anywhere. People don't want to reveal the negative findings. Don't want to highlight negative findings in any studies.
Okay, thank you. Thank you.
I would like Dr. Jamalul Azizi to facilitate our chairman, Professor Mohammad Shamili. Now I would like Professor Mohammad Samim to facilitate Dr. Huma Mustafa, Joint Director of Council for Science and Technology, UP. Moving on to our next session, I would like to invite our chairperson for the session 3, Dr. Prashant Bhatia. Please come to stage. Dr. Nazia Mahfouz and Dr. Salahuddin.
Invite Dr. Obaid Siddiqui, who is the assistant professor in our own college, JNMCH, to give his talk and enlighten us.
The differences that we encounter when we do that anesthetic or sedative regimes in an ICU setup. So straight away, bronchoscopy is an endoscopic technique to visualize the inside of the tracheobronchial tree for diagnostic and therapeutic purposes, and the procedure is very uncomfortable to the patient if not adequately sedated. The patient may complain of pain, nasopharyngeal discomfort, and they are associated lot of anxiety before you take the patient inside the bronchoscopy suite. So that is why we need to have certain kind of sedative regimes and topical airway anesthesia to reduce the discomfort of the patient for that bronchoscopy, or for that matter any kind of procedure that you are performing onto the patient. A brief introduction about the techniques. So flexible bronchoscopy is preferably used for diagnostic and therapeutic purposes, while rigid bronchoscopy may be used for more selected procedures like removal of foreign bodies and longer procedures like treatment of tracheal stenosis, placement of silicone airway stents. So anesthetic considerations for both flexible bronchoscopy and rigid bronchoscopy usually differ, and for today's talk we'll be restricting ourselves to the techniques that we'll be using in flexible bronchoscopy. Anesthetic technique. So how do you plan for an anesthetic technique in any procedure? And today we'll be talking about bronchoscopy. So that will depend upon the procedure that you are planning in that particular patient, and that procedure can be a basic diagnostic procedure or an advanced diagnostic procedure, or it can be a therapeutic procedure. Then there are certain things that you need to look into the patient before you plan for sedatives that are to be given into these patients. So you will have to have an idea about the severity of the patient's lungs, the reserve that the patient, the cardiopulmonary reserve that the patient is having at that point of time, and any comorbid conditions that the patient may be having at that point. And obviously, preference of the bronchoscopist, the anesthesiologist, and the patient is paramount, because sometimes you may find stable patients who will come inside the bronchoscopy suite and they will be only comfortable with, they just want topical airway anesthesia without any sedatives. So that needs to be taken into account, what the bronchoscopists want, what are the limitations for anesthesiologists, and what really the patient wants, how comfortable is the patient inside the endoscopy suite. Before we plan for, as an anesthesiologist, before we plan for inducing any sort of patient by delivering sedatives, anti-anxiety or inducing agents like propofol or ketamine, we need to have a pre-operative assessment. So that is paramount for an anesthesiologist. So you need to have a brief historical assessment, whether the patient is complaining of any potential bleeding. The patient may be on certain kind of anticoagulants, because many of these patients will be on anticoagulants. You need to have an idea about the respiratory status of the patient, the cardiac status of the patient, any adverse reactions to previous bronchoscopy, and what were the indications for previous bronchoscopy, or was that bronchoscopy associated with any kind of complications in the previous bronchoscopy. So you need to document these findings, and you need to really have an idea before you plan for a sedative regime in these patients. A brief airway examination. We as an anesthesiologist are very fond, or are very careful going for an airway examination, because you are inducing these patients, you will be delivering a lot of drugs that are respiratory depressants in these patients. So you need to have a brief airway examination also, because at times you may need to intubate these patients in the endoscopy suite. So having an idea about how difficult that intubation can be in the bronchoscopy suite, you need to examine the airway in brief. And what you need to examine, you give a brief outlook about the nares or mouth for any small lumen, because that may be problem for putting inside the bronchoscope, any nasal deviation, any congenital deformities or loose dentition, because at times you may have elderly patients who will be having loose dentitions. They will be having they will be edentulous patients with certain kind of artificial dentures, and that may pose a problem while you plan for intubation in the bronchoscopy suite. Then Mallampati score, we usually do this Mallampati score to define the difficulty of intubation in the intraoperative period, but that can also be done in the preoperative period in the pre-bronchoscopy suite also. Any short neck or any jaw deviation, and of course any disease of the cervical spine, because you will have to then position the patient accordingly, and any unstable cervical cord injury, you may convert a stable cervical cord injury into a unstable one. So you need to have a brief examination of the neck also to rule out any cervical stenosis or any cervical spondylitis in these patients. Like I said, a lot of these patients will be on anticoagulants, and you need to have an idea about the amount of clopidogrel and the warfarin these patients may be having, and then you need to stop these drugs before the bronchoscopy. And the guidelines are basically there will be two drugs that you will be encountering, three drugs rather: clopidogrel, warfarin, and aspirin. So while we encounter warfarin, we will be first dividing the patient into low risk condition and high risk condition, and these low risk conditions will be prosthetic metal walls in aortic location, xenograft heart walls, and more than 3 months after an episode of venous thromboembolism. And in these patients, you do not need to, you will be stopping warfarin 5 days before the bronchoscopy procedure. Get an INR done in the evening of the surgery. Try to maintain an INR less than 1.5. And once that procedure is done, you can start the warfarin on the evening of the surgery. Similarly, on a high risk patient who is on warfarin, again you need to stop warfarin 5 days before bronchoscopy. But since it's a high risk patient, you will be taking the patient on a low molecular weight heparin for that intervening period. Stop the low molecular weight heparin about 12 hours before bronchoscopy. Once the bronchoscopy is done, then restart warfarin in the evening of the bronchoscopy, but overlap that low molecular weight heparin with the warfarin, and ultimately you can taper the low molecular weight heparin depending upon the INR. Similarly, for clopidogrel in low risk conditions, you will have to stop clopidogrel for about 7 days prior to bronchoscopy, and high risk conditions like coronary artery stents, you need to have a cardiology reference. Because to just outweigh the benefits that bronchoscopy may be having in that patient, and you need to stop clopidogrel 7 days before surgery. And remember, most of these patients who are on clopidogrel and aspirin, if they encounter bleeding in the intra-procedure period, the bleeding will be massive, and it's something kind of a very great a complication that will be very difficult to manage, because we have seen in our ICU we have seen patients who are in clopidogrel and aspirin, and we did a bronchoscopy and we found that post-operatively or post-procedure the patients were bleeding heavily, and we have to call the pulmonologist to manage that bleeding. So remember to stop, to document the amount of warfarin, amount of low molecular weight heparin, and the clopidogrel or aspirin for that matter that the patient is having at that point. But you can continue aspirin, you have to stop clopidogrel and warfarin. So pre-procedure fasting guidelines, this is what the American Society of Anesthesiologists recommends: 2-4-6, that is 2 hour nil per orally for clear liquids, 4 hours for breast milk, and 6 hours for light meal. But now these guidelines have changed, and a nil per orally for 4 hours will suffice for a bronchoscopy in the bronchoscopy suite. IVSS is mandatory. You need to have an IVSS, and that should be maintained throughout the procedure, because you never know the kind of complications that you may land up into the bronchoscopy period. Coagulation studies like PTINR, blood counts, APTT, and hemoglobin are only indicated if there are any known clinical risk factors for abnormal coagulation, like patients of chronic liver disease, patients of chronic kidney disease, patients who are on anticoagulants, patients who are of known any sort of a hematological malignancy. So you need to have a pre-procedure investigation checkup in these sort of patients also. Remember, pre-medication for bronchoscopy is not recommended, because we are very fond of using, many of us are very fond of using atropine and glycopyrrolate to manage vasovagal episodes in the intra-bronchoscopic period. Guidelines recommend not to use any sort of pre-medication in patients who are for bronchoscopy. Remember to apply all sort of monitoring of vital signs is recommended to confirm any systemic and hemodynamic complication. The guidelines recommend that ECG monitoring in patients only is to be done at high risk for cardiovascular complications who are known case of coronary artery disease, patients who have an episode of myocardial ischemia more than 6 weeks back. So these are the patients where you need to apply a 3-lead, a 5-lead, or for that matter a 12-lead ECG. But in normal stable patients, ECG monitoring as a routine is not recommended. What you need to do is to have an SpO2 and heart rate and a blood pressure and a non-invasive blood pressure monitoring. Supplemental oxygen is to be delivered through a nasal cannula or through the bite block to keep the SpO2 greater than 90%, and there are no routine recommendations to use EtCO2 monitoring in the bronchoscopy suite. So talking about the regimes, basically there are variety of regimes. You can either use just topical airway anesthesia alone, you can use topical airway anesthesia combined with sedation and analgesia, or for very longer procedures and complicated procedures inside the operating rooms, you can then go for full general anesthetic technique. But the most commonly technique that is being used by the bronchoscopist and by the anesthesiologist in the intraoperative period for awake fiber optic, we basically use topical airway anesthesia with a combination of a sedative and an analgesic regime. It's the most commonly employed method, and it is indicated in any patient who is cooperative. The duration is brief, patient has a stable respiratory status, and if you plan for like if it's a daycare procedure, which most of the bronchoscopies are. So we'll be discussing about topical airway anesthesia with sedation and analgesia. General anesthesia is only indicated when the patient is unable to tolerate bronchoscopy due to high levels of anxiety, if there is severe lung disease, or patients who are morbidly obese where you are not sure of maintaining the airway in the bronchoscopy suite, or if you require, or if the bronchoscopy requires for paralysis for intraoperative period. Very long or complex procedures, endobronchial ultrasound, electromagnetic navigation, bronchial thermoplasty, and procedures requiring rigid bronchoscopy will be requiring general anesthesia, and we'll not be discussing general anesthesia in detail today. So topical anesthesia, you must all be aware that local anesthetic of choice is lidocaine. And why it is the local anesthetic of choice? Because it has a rapid onset, a very huge safety margin, and it is available in a lot of concentrations from 1% to 10%. You can have lidocaine, you can have a lidocaine gargle, you can have a lidocaine spray or injection. So that is how the margin that we have with lidocaine makes it the topical anesthetic of choice. There have been use of cocaine and benzocaine, other local anesthetics, but now the topical anesthesia of choice is lidocaine. Now how do we do it? These techniques of giving topical airway anesthesia to bronchoscopy patients differ in various institutions, and there is no defined protocol as such. So what we really do in our setup, we first make the patient gargle with about 4% lidocaine, and that will be producing topical anesthesia of the mouth and the base of the tongue. Then we apply 2% viscous lidocaine jelly to the nostrils if the nasal route is preferred, which will be followed by spraying around 1 to 2% lidocaine in the oropharynx and in the laryngopharynx. Finally, the flexible bronchoscope will be introduced, and when you introduce that flexible bronchoscope, when you reach at the level of the vocal cords, you will be spraying about 2% of lidocaine at the level of the vocal cords, which will be then followed by 1 to 2 ml of lidocaine down into the trachea, and once you reach into the carina, another 2 ml of lidocaine will be sprayed and spread. Remember, when you use lidocaine, you have to limit to the maximum dose that you can deliver to that patient, and this maximum dosage has been defined in various studies, and you can find that from a minimum of 3 milligram per kg to about maximum of 9.6 milligram per kg doses have been described. But most of the texts, basically they mention that about 6 to 7 milligram per kg of lidocaine will suffice for a patient, and that is the upper limit you can use in a patient where you are trying to give topical airway anesthesia. So what we do, we basically give about 50 ml of 4% lidocaine gargle, which is most of that gargle is expectorated by the patient, and about 20 to 20 ml of 1% or 2% atomized, that is through the spray that we are delivering to these patients. Some of us may be very fond of using nebulization with 4% lidocaine, but the guidelines tell that nebulization is not recommended as a technique for delivering lidocaine to the airways. it's not the technique of choice basically. Then we may also go with transcricoid or transtracheal injection, but again it is not been defined. It is basically discouraged as a first line technique because it requires certain kind of special training and specialization, and it is associated with certain complications also. So when you use lidocaine, you need to have an idea about the signs and symptoms of lidocaine toxicity, and you find that these symptoms can vary from very mild nausea and vomiting to very severe like convulsions, coma, respiratory failure and cardiac arrest. So you need to have an idea about, because any amount of drug that you are using and any kind of anesthesia is basically a virtual science. You do not know how that patient is going to behave on what particular dose of a patient. So some of the patients may develop toxicity at 4 milligram per kg. Other patients may be very comfortable with very high doses of about 9 milligram per kg. So you need to have an idea when with the time to intervene, when the patient is complaining of lidocaine toxicity, and you need to have an idea about the signs and symptoms of lidocaine toxicity. The drugs that we use for sedation and analgesia, basically it has to be combined with topical airway anesthesia, and when you plan for an ideal sedative specific agent, there is no ideal sedative agent that has been defined till now. But when we practically talk about delivering drugs, we need to have an idea about the properties of that particular drug. It should have minimum respiratory depression, it should cause minimum hemodynamic stability, and medications with rapid onset and very short duration of action are to be chosen because of their easy titratability, and at the moment you find any adverse effects happening, you can stop infusing that drug. So these are the qualities that you need to have in a patient, in a drug that is to be infused. This is the degree of sedation by the American Society of Anesthesiologists, because now when you plan to sedate a patient or anesthetize the patient, you need to have an idea about the degree of sedation that you need to produce in that particular patient and how it has to be defined. So grade 1 is minimal sedation, it's just anxiolysis. It's a drug induced state where the patient will only complain that there is no anxiety, the hemodynamics will be maintained, the respiratory status will be maintained, and the patient will be usually awake with all the purposeful movements on verbal command. Then moderate sedation, where the patient will remain drowsy. You are adding analgesic to a sedative regime, the patient will remain drowsy, and only on certain kind of a verbal or tactile or a painful stimulus the patient will show a purposeful response, but the patient will be having a stable respiratory hemodynamics and a stable cardiovascular dynamics, and this is called as conscious sedation and monitored anesthesia care for that matter. And this will be the state that you as a bronchoscopist or we as anesthesiologists will be using most commonly in most of the bronchoscopy procedures, that is conscious sedation. Then deep sedation and analgesia, it's again a drug-induced state where the patient will be only responding to painful stimuli. You will not be sure that the patient will be able to maintain the airway, but the cardiovascular status will remain normal. And then finally the general anesthesia, which is a sleep-like state where the patient will not be responding to any painful stimuli, the airway will be compromised, you need to intubate these patients, and cardiovascular function will also be compromised. So just a brief view of the agents. Benzodiazepines are one of the most commonly used drugs because of their sedative, hypnotic, anxiolytic and amnestic properties. And this amnesia is, remember, it's an antegrade amnesia, because what you are performing now, the patient will forget in the post-operative period what really happened to the patient. So antegrade amnesia is a unique property of benzodiazepines. Most commonly used drug is midazolam. Remember to use only 1 milligram per ml concentrations inside the bronchoscopy suite. This drug is available in variety of formulations like 2 milligram per ml, 5 milligram per ml, but you need to use 1 milligram per ml so that you can easily titrate the drug in the bronchoscopy suite. Intermittent intravenous dose is recommended, tailored according to the patient response. Dose is 0.5 milligram to 1 milligram increments that has to be given at 5-minute intervals. The maximum dose can vary between 0.01 to 0.1 milligram per kg. The onset is very fast, within 30 seconds to 1 minute, and the duration of effect is 2 hours. So it has a long duration of action. You need to avoid this drug in elderly patients and obstructive lung disease because they are very prone to land up into respiratory depression. Opioids for long has been called as God's medicine because of their unique properties. They are sedatives, they are analgesic, and they also have an antitussive effects. And because of these properties, these drugs, opioids, are very commonly used in these patients. Fentanyl being the most commonly used. It has a rapid onset, very high potency, and a very short duration of action. The dose is to be given in increments of 50 to 200 microgram. The onset is 5 to 10 minutes. Duration is relatively larger, 1 to 2 hours, and these drugs are prone to develop land the patient into respiratory depression, hypotension, and bradycardia. Propofol is an alkyl phenol sedative and hypnotic agent, and the unique property of propofol is that it causes a very clear-headed recovery in the post-operative or in the post-bronchoscopy period, or any procedure when you plan bronchoscopy with propofol or endoscopy with propofol, or any patient with daycare procedure. It causes a dose-dependent degree of sedation from conscious sedation to general anesthesia. So it's an advantage also, and sometimes it's a disadvantage also. It causes rapid onset and rapid recovery. That is what I was talking about. Clear-headed recovery in the post-bronchoscopy period. Recovery that is favorable, better than even sedatives like midazolam and opioids. But it has risk of apnea. There is disinhibition and loss of patient cooperation, because when you exceed the amount of drug that has to be infused, you may have patient in cooperation and disinhibition. The drug causes hypotension, decreased cardiac output, and injection at pain site. So it should be avoided in patients where you assume the patients to have a challenging airway, like morbidly obese patients, a short neck patient, elderly patients. The dose is 0.5 milligram per kg over 1 minute. So remember, this is a sedative drug. This is the sedative dose. It's not the inducing dose, which has to be maintained by an infusion of about 1.5 milligram per kg per hour to 4.5 milligram per kg per hour. The onset is relatively short, 30 seconds only, and duration. This is the advantage. The duration of this drug in patients is only 3 to 5 minutes when we compare that duration to fentanyl and midazolam, where it was 1 to 2 hours. So it causes a clear-headed recovery, but it has a narrow therapeutic window between conscious sedation and general anesthesia, and the guidelines do not recommend infusing propofol without being attended by an anesthesiologist. But it's a wonderful drug. The only disadvantage is that you may really never know that when the patient has landed into conscious sedation to general anesthesia. So you need to have an anesthesiologist by your side when you plan for a propofol anesthesia. Dexmedetomidine is a relatively newer drug, and we are very fond of using this drug because of its wide variety of therapeutic index and practical profile that we encounter. We are using it for awake fiber optic for intubating. We are using it for maintaining the hemodynamic stability. We are using it for sedation. We are using it in lumbar spine surgery, in spine surgery to decrease the anesthetic inhalation anesthesia and all those drugs. So this is a wonderful drug. It's a selective alpha-2 agonist. It has sedative and analgesic properties. And the advantage of using dexmedetomidine is that it causes sedation without respiratory depression. So that's the unique advantage of using dexmedetomidine, and patients are easily arousable. So it becomes useful in patients with respiratory depression where you want to avoid sedation, but you want to maintain the airway of the patient, and you want the patient to breathe spontaneously in patients of obstructive sleep apnea and morbidly obese patients. So the dose is 1 mics per kg bolus that has to be given over 1 minute, followed by infusion of 0.2 to 0.7 mics per kg per hour. And the disadvantage is that it has vagomimetic properties, and patients may land up into bradycardia. So in patients who have coronary artery disease, who are prone to land up into certain kind of arrhythmias in the intra-procedure period, you need to avoid dexmedetomidine. But it's a wonderful drug, and there are no recent trials that have come up, but it is now being used preferably by many bronchoscopists and anesthesiologists for variety of procedures. Ketamine is an NMDA receptor antagonist. The unique property is that it has bronchodilator properties. It's an agent that is very commonly used in children in a dose of 0.5 milligram per kg. And it also causes sedation without respiratory depression, and all the reflexes are maintained while you sedate the patient with ketamine. All the airway reflexes and gag reflexes are maintained. So that is a disadvantage of using ketamine for sedating, but it is now very commonly being used for sedating children. The disadvantages are that it causes increased oral secretions, disturbing post-operative hallucination, and it's a sympathetic mimetic drug. It will cause hypertension and tachycardia. So avoid using this drug in coronary artery disease patients. How you deliver oxygen delivery? Through a bite block at 10 liter per minute, or it can be via a nasal cannula through 2 to 5 liter per minute. There are certain other techniques like high flow nasal oxygen, and use of specially designed an IV mask. You can insert a bronchoscope through that an IV mask. So that I'll not be discussing in detail. Post-procedure assessment, supplemental oxygen has to be continued in the post-procedure period. Patients should continue to receive oximetry and be monitored till they return to their full consciousness. The return of gag reflex, assessment of return of gag reflex is very important, because lidocaine will be causing vocal cord paralysis and will be blunting the gag reflex. So you need to have a very sure idea about the return of gag reflexes, only then you can ask the patient to take the food orally. Sedation and analgesia in ICU, how that is different, just I'll not be discussing the ventilatory parameters because I believe that will be talked about in the next presentation. But how the drugs are being maneuvered, I'll be only talking about those things. Fiber optic bronchoscopy facilitates inspection of the upper airways and bronchial tree in critically ill patients, and most of these patients are mechanically ventilated either on a tracheostomy tube or on an endotracheal tube, and they are associated with many comorbid conditions. So these patients will be prone to land up into hypoxia, arrhythmias, hypotension. So that needs to be taken into account when we plan for a bronchoscopy in the ICU, and usually it should not be done very routinely in ICU unless there are specific indications to use bronchoscopy in an ICU setup. Then only bronchoscopy is to be used if there are any specific indications. As a routine, you need to avoid bronchoscopy in patients who are in ICU. So potential benefits have to be outweighed against the risk, and all possible risk factors like any bleeding tendency, any decreased cardiopulmonary reserve, any arrhythmias, hypoxia have to be corrected before you plan for bronchoscopy in ICU, because these patients will desaturate very rapidly while you insert a bronchoscope. Specifications of bronchoscope are very important. So if you there have been studies where it is stated that when a bronchoscope, a 5.7 mm bronchoscope is introduced in a spontaneously ventilating patient, it will occupy only about 10 to 15% of the normal airway anatomy. So when that similar bronchoscope is introduced through a 9 mm endotracheal tube, it will occupy about 40% of the size of the endotracheal tube. And when that same bronchoscope is introduced in a size 8 mm bronchoscope, it will occupy about 66% of the diameter of the endotracheal tube. So that is something that you need to take care of while you plan the type of bronchoscope and the size of bronchoscope, because then that will be hampering the ventilation through the ventilator basically. Rice tube feeding has to be stopped. Whenever you deliver anesthesia or sedatives, you need to have a verbal informed consent by the patient's relative in ICU. Pre-oxygenation for 3 minutes with 100% oxygen is mandatory, and this 100% FiO2 should be continued during bronchoscopy and in the immediate recovery period. In the ICU, it is the clinical status of the patient. So you do not have to have preference by an anesthesiologist or a bronchoscopic or a patient because the patient is already on mechanical ventilator. It is basically the clinical status of the patient that will determine the amount of drug and the type of drug that you will be using in bronchoscopy in the ICU period. So for that matter, if you have a patient who is a known case of hypotension, the patient is developing hypotension, we'll be avoiding drugs like propofol and thiopentone for sedating these patients. Then the choice moves on to ketamine or etomidate. Drugs like these are to be used for sedation. Similarly, if you have a patient a patient of bronchial asthma, you need to have a drug which has bronchodilator properties, and we would like to induce, or we like to sedate these patients with ketamine-like drug, because these patients will be are on bronchial asthma, and ketamine has a bronchodilator property. A patient who is on a spontaneous mode, who is on a spontaneously ventilating patient, and you do not want the patient to land up into respiratory depression by your drugs, so you will be using a drug like dexmedetomidine, which will cause sedation, but it will avoid respiratory depression. So it is basically the clinical profile of the patient in the ICU that will determine the type of drug that is to be used. But nevertheless, the most commonly used drugs remain propofol, fentanyl, which is a synthetic narcotic, and it will suppress cough and it will provide profound analgesia in these patients. And sedation can be achieved by using midazolam and propofol. So in ICU, we usually avoid midazolam because we have a kind of a broad margin to deliver these drugs. So we can use these drugs in higher quantities than bronchoscopy should. And we basically prefer propofol and a combination of fentanyl for bronchoscopy in ICU. Muscle relaxation can be considered for if the bronchoscopist wants certain complicated procedures or certain complications that develop. You can use muscle relaxation because a stable, not moving patient is relatively very easy for a bronchoscopist to perform bronchoscopy, and this all kind of muscle relaxation techniques have very wide safety margins. So you can use any drug like rocuronium or a norcuron in these patients if you really plan for a complicated procedure in ICU. Some of these patients who are spontaneously ventilating patients on a spontaneous mode, they may be requiring only very light sedation, and just a small dose of midazolam combined with topical airway anesthesia will suffice in these patients. But remember that attendant staff in ICU has to be very trained, because a lot of complications related to hemodynamics and respiration may develop in these patients. So your nursing staff has to be trained enough to inform you about any kind of complications that are occurring, like hypoxemia and arrhythmia. So continuous monitoring is recommended in these patients, including ECG. Anesthetic techniques are usually not required. It's only when the bronchoscopist wants us for complicated procedures or certain complications that develop while the bronchoscopy was being performed. And this can be divided into IV induction agents, where we use propofol, ketamine, etomidate, and thiopentone, and maintenance drugs like volatile anesthetics or total intravenous anesthesia. Sometimes the bronchoscopist may demand a neuromuscular blockade. So inhalational anesthesia, usually we use sevoflurane or isoflurane, and inhalational sedation has been described in many studies in the ICU also. But in a setup like ours and in most of the Indian setup, we require specialized devices to deliver inhalational anesthesia in the ICU setup. So it is not a technique of choice basically in centers where you have devices like Anaconda machines that are inbuilt vaporizers to deliver inhalational sedation by isoflurane. It's only at that places it is indicated. But yes, inhalational sedation is a technique of sedating patients for bronchoscopy in ICU. We usually do not do these sort of techniques. Total intravenous anesthesia, combination of propofol and opioids, has to be infused through an infusion pump in these patients. And the advantage are that you are avoiding inhalational anesthetic agents. There is no waste of anesthetic agents, and it does not cause ICU or OT room pollution. So to conclude, flexible fiber optic bronchoscopy is a very important and useful tool for the pulmonologist to diagnose and treat various pulmonary disorders. With proper preparation of the patient and close monitoring, fiber optics can be performed with the desired outcome, and choosing the proper level of sedation along with adequate topical anesthesia can make the experience better for the patient and the bronchoscopist. Thank you.
Thanks, Dr. Obed, for the
Fentanyl and midazolam. So what we are doing topical airway anesthesia, and then straight away going with dexmedetomidine. And it's a wonderful drug. There are a lot of it is just not a sedative. It is an anesthetic. It is an analgesic. It causes hemodynamic stability also. It lets us to reduce the doses of anesthetics that we are using in the intraoperative period. So yes, hypotension and bradycardia have been reported, but we do not commonly encounter hypotension. Bradycardia has been reported in some cases in our center also, and it's not life-threatening. It responds to atropine, so it's not life-threatening bradycardia.
Thanks. Any more questions?
Thanks, Dr. Bess, sir, for fantastic presentation, and you have covered most of the topics. But the one question rising in my mind, I am new pulmonologist, and right now I am handling the 16-bedded ICU independently in the Varanasi. So my question is, if suppose that this patient is intubated and mechanically ventilated, sedated and paralyzed, and if any bronchoscopic procedure is needed, is there any still need for topical anesthetic of the airway by nebulization or any means?
Because since the patient is already paralyzed and you are saying that the patient is already sedated, the only thing that you need to assess in that patient is some amount of analgesia that you need to. Because if you are using a sedative like a midazolam infusion or a because most of these patients will be on midazolam infusion, some patients will be on propofol infusion, you need to have a certain kind of analgesic, and that fentanyl will suffice in this patient. So for bronchoscopy in ICU, what I would recommend is to go with a combination of a fentanyl-like drug with propofol. That will suffice, and if neuromuscular blockade is needed for that particular procedure. But now muscle relaxation is not a technique that is to be used in ICU. It has to be avoided in all kind of ICU because that will lead to critical care myopathies and all sort of illnesses. So muscle relaxation infusion is not indicated unless there are specific indications like ARDS and other things. So muscle relaxation is only when the bronchoscopics demands from the anesthesiologist that I need muscle relaxation. That is the only indication. Priority, you should avoid using neuromuscular blocker in these patients, in any patient for that matter who is in ICU.
Yeah, okay. Previously I was in Gangaram and Dhamija sir was there, and most of the patients when he was doing the bronchoscopy, sir, most of the patient was intubated, sedated, as well as paralyzed.
As a procedurist, I would preferably want my patient to be given a short-acting, maybe atacurium, And
Just
to
that-
make the
Yeah.
procedure more comfortable for me, the yield will be more. If the patient coughs in between and not able to get a good return, it really doesn't make a sense. Especially if you have to do a lung biopsy in an ICU, I would always
Yes.
be kind of happy.
Exactly,
if my
sir. That's
anesthetist gives
that
me
what I
a-
mentioned also. If the procedure is demanding, you need to have certain time, or if certain kind of complications develop, you can use neuromuscular blockers. But there are no specific indication to use neuromuscular blockers in every patient.
No, of
Ideally,
course
they
not.
should be avoided in
Of course
patients
not.
who are yes.
100%.
But if the bronchoscopics demand, the
100%
procedure
agree.
demands, we can deliver short acting like
Yeah,
atracurium.
we normally use atacurium only. because
So
the
there is
procedure
no
would
harm
last
in
for more
giving,
than 5 to 10 minutes anyway.
Exactly.
Actually, sir, the issues with me that when I have started the bronchoscopy in the ICU, in the same way what I learned from the Bungaram and from the Aligarh AMU. So, sir, the new issue is that whenever patient is sedated and paralyzed and intubated, and I start to perform the bronchoscopy. So, initial 5% I have done, and 2% land up into 1% land up into bradycardia, and 1% land up into asystole. Fortunately, both the patients are revived. After that, sir, empirically, I started to nebulize with 2% xylocaine, even patient is sedated and paralyzed. And after that, we have done the 15 procedure, and no any such type of event has been happened.
I think it would be more because of the compromise of the airway during the procedure
Exactly.
than
Exactly.
anything else.
Asystole
I
is
could
not a
gather.
complication of drugs that
It will not be a complication of any of the drugs that you would be routinely using.
Hypoxia
for,
is the most common
Maybe it
cause.
is hypoxia which was troublesome
Exactly.
to the patient during the procedure, which led to.
But sir, after whenever I started the topical anesthetic for the airway, then so there is also have issue of the hypoxia, but no any patient have been land up into bradycardia.
We
Sir.
have not come across such
Just
instances.
practical aspects
trying
what I
to-
have, I'm facing here.
I'm trying
Just
to
I'm asking,
analyze
sir.
your situation, but I couldn't find a reasonable answer except for hypoxia to explain what really would have happened.
Thank you, sir.
Here, very nice conference, and it's nice to know that a lot of the boys who are here have actually worked with me in Apollo and in Max, my 2 hospitals in Delhi. I think 4 or 5 of the photographs I recognize from the first alumnus. Prashant Bhatia was in our ICU, and Vivek Nagya, Dr. Shamim, Dr. Nafiz, Dr. Richa Tomar, and one other internist who is now in Singapore as a nephrologist, Dr. Manish, one of a very bright doctor. So I've had a good fortune to interact and work with many alumni from Professor Varga's unit and the hospital here. So this is a bit of a controversial issue, because when I was hearing the talk by the anesthetist and the question and answer session, so what I'm going to talk is just from my experience, not too much from the literature. And there's actually scanty literature of bronchoscopy in the ICU, because it's not something which you can, it's very sort of observer related. It's something which is, there's a lot of bias. Some people do things, some people don't. We heard from the chairperson also his experience. We heard something else from Hamid Hamija. I'm going to tell you my experience. So some of the topics have been issues have been covered in the earlier talks, including the talk by Professor Azizi on hemoptysis, which is an important feature of bronchoscopy, in my view. It's a very important feature of bronchoscopy in ICU, because 90% of hemoptysis is still going to be treated with fiber optic bronchoscopy in ICU in most centers. So the approach to bronchoscopy, the talk given was bronchoscopy technique in ICU, in the ventilated patient, invasive and in the non-invasive. I've sort of adapted it to that, and to bronchoscopy in the critically ill, because when a patient is in the ICU, he often needs a bronchoscopy when he's critically ill. He's in the ICU. He may not be on ventilation, but he's often on the threshold of ventilation. And as the previous Dr. Obaid mentioned, you should try and avoid bronchoscopy in the ICU. So I take strong exception to that. I feel the indication, the contraindication to bronchoscopy in ICU is often the actual indication to do the bronchoscopy in ICU if you're sufficiently experienced, if you see the tempo of the disease you're treating, and all that has to be taken into account. It is not as satisfying and glamorous as removing a tumor or doing electrocautery or debulking. However, all pulmonologists, I think, because they will be on call and they'll be working in departments, will be on call at night and in daytime, and they should all be conversant with the bits and pieces and procedures and ancillary equipment required to bronchoscope in an ICU. And so it's an important topic which has special sort of situations you'll find yourself in, special considerations also. And I remember when I moved from my last hospital, from Apollo to the Max Hospital, I was amazed because every patient in the ICU wanted a bronchoscope. The intensivist said he's not fit for bronchoscopy. Or my colleague pulmonologist would have refused that patient. And I felt that I've been bronchoscoping these patients the last 5-10 years, and nobody's collapsing. So it's a way of thinking, and it's a way of using your equipment, and the way of being safe while doing it, and the way you use your anesthesia, and the way you use your relaxant, and the many little tips on this. So some special situations is, as Dr. Amit Dhamija said, you need to biopsy the failing lung and not just say he's in lung failure, you can't biopsy. Once in a while you need to. As microbiology techniques have improved with the gene expert, with the respiratory pathogen profile test where you can pick up PCP more easily and with accuracy and other tests, the need to biopsy the failing lung or the immunosuppressed patient is decreasing. I would accept that. But once in a while you need to do it because your lavage may not give you the answer. We may do it as a 2-step procedure. You need to scope and do BAL even in severe respiratory failure in the spontaneously breathing patient. And we keep saying, no, he's too sick. He'll be sicker the next day and sicker the next day. And then it'll be too late to get the answer from the lavage. So you have to be very aware of what you're treating. It's just not a technical thing of putting down the scope. You have to manage the patient and see how he is, what he was before, what is the tempo of the disease. Has he used an antibiotic? Has he not? And hence time your procedure to get the optimal result. So do you need to scope during NIV and vent support? Yes. If you read some of the books or the articles, a patient on NIV support was a contraindication. Not has become a very easy indication if you have the right technique and the right mask with the port, which I'll show in the workshop. Do you need to provide guidance for a fiber optic guided intubation, a difficult airway? So morbid, obese, very obese patient, you have to give very minimal sedation with or without DEX, burns, airway problems, airway fistulas, anticipated, unanticipated, ankylosing spondylitis. All these things need a fiber optic guided intubation in the ICU often or in the OT, either through the nasal or oral route. You have to choose your equipment, choose the size of the bronchoscope, choose the size of the ET tube. The flexible bronchoscope, the flexible scopy in the bleeding patient, right? So there you have diffuse alveolar hemorrhage, which is an ICU scenario, and you may need to bronchoscope to prove it is diffuse alveolar hemorrhage and not the coagulopathy causing sort of bloodstained secretions. And then, of course, bronchoscopy in the badly bleeding patient, where you may have to put in a blocker, as Dr. Jamalulul said, and there's certain techniques. If you never used a blocker before routinely, you never need to know how to do it in a sick patient. And then the upper airway issues, I'll try to show you some videos on patients who have some various forms of airway stenosis, burns, and dynamic airway collapse. So the talk is, these are sort of some issues I will be considering, how to do it, what is the technique, how to prepare, some physiological considerations. So some of these have already been touched in the previous talks. So the talk is for the ICU resident, the trainee, the first year, second year resident here in this hospital, who's going to be asked to assist in the procedure. For the anesthetist, intensivist, or the trainee who may have to do the procedure even when he does not have enough experience in the middle of the night. And then the talk for the experienced pulmonologist, even for the experienced intensivist, is to understand the timing, indication, precautions, contraindications, with particular reference to the ICU patient. Right, so the technique will be discussed, and I think I'll first go into the contraindications and indications, and some physiology, which has already been touched. So the normal trachea, when you put the scope in, is 10%, it goes up to 50%, so there's a lot of resistance when you go through an ET tube. And the airway, important thing to remember, is the airway pressures are different depending on where it is measured. So when people have done a study, Lindholm etc., a study where they measure the pressure through the suction channel at the tip of the bronchoscope, that pressure is much lower than what you're measuring in the vent gauge at the back end of the tubing. And the inspiratory resistance to flow lead to these high peak pressures, which may not be as high actually inside the lung. So the loss of tidal volume during the bronchoscopy, the PEEP fluctuates, the high inspiratory pressure levels, and you probably have to set up an alarm at some cutoff value, and the carbon dioxide may rise if you notice it by doing an end-tidal CO2, which you may or may not do, and the oxygenation falls. So these are the pressures. I won't get into this because it's more theoretical. From a practical point of view, there's some good old books or old articles I've found to read. 92 by Dellinger, very, I think, well-known anesthetist, intensivist from the US. This is a Swiss article, but nice points given. And then a nice article in the Journal of Bronchology, nicely covered topics. If juniors want to read this, in this by Fragasso, and someone from Singapore called Tai MH in the intensive, more recent, but there's not very much stuff being written on this in a formal way. So what are the indications? When would you do it? To obtain BAL, especially in the immunocompromised host, and you must always remember to look at the BAL return fluid, especially in the alveolar hemorrhage scenario. On the rare instance, once in 10 years, you'll see an alveolar proteinosis with some milky white fluid, and of course, purulent secretions. You can do a transbronchial lung biopsy once in a while in the ICU scenario, and you can often do a TBNA in the ICU scenario. Conventional TBNA, we just did a EBUS TBNA just 3 days ago in a patient who actually got renal transplant, respiratory failure, too sick for bronchoscopy, cancelled for 2 days. Well, he was not getting better, so we did it, and we did conventional TBNA, got very scanty black stuff from the subrenal node, then converted to EBUS TBNA on 10 liters oxygen, and got acute septate hyphae from the TBNA material and PCP on the lavage sample. So it was worthwhile doing it. It got postponed for 2 days. So you can do that really, but more importantly, you often have to do it besides for tumors, for aspiration pneumonias, for diagnosing weaning difficulty when you have severe bronchotracheomalacia, edema of the airways, burns. Sometimes you can pick up a TOF in difficult weaning situations, and the site and site of hemoptysis, and is it alveolar hemorrhage and weaning difficulty. So these are some of the indications. This is just an interesting case I'll just show very briefly. Of a patient who had KMNO4 alkali burns, and he has a very unusual sort of torn sort of epiglottis, this yellow stuff, broken in parts. He had taken for suicide, and this is his airway, all burnt inside, and after bronchial toileting, it got a little better. Video's not running. Then he ended up with tracheobronchomalacia and tracheal stenosis sometime later. So then he came with recurrent, he's on a trachea, you can see the blue tube of the trachea. 3 months later after that, he comes back with tracheobronchomalacia, this is the tip of the tube, and you cannot see the carina, it's deeper inside, and the stenosis, and a 6 millimeter bronchoscope can't pass through that. And this is a deformed long tracheal stenosis. So sometimes you'll have to pick up these things, and you don't need to be very, very experienced as long as you're aware of this. Same images once again. Another case with weaning difficulty with tracheobronchomalacia. This patient had an emergency intubation. I think he got traumatized during the intubation. And this is a patient with subglottic stenosis who has just under the cords, he's got this. He's on a tracheostomy right now because we're not able to wean him. And then we realize he's got that ulcerated thing. He's got this swollen mucosa, granulation tissue, and this is after we remove the tracheostomy. We can look inside, and you'll find a severe amount of, I think, dynamic airway collapse. That's the trachea, and then the trachea is removed. The trachea is working as a stent actually sometimes, and when the trachea comes out, the whole airway collapses further. And you see the right main stem bronchus is extremely narrowed compared to the left. The right main stem tends to collapse more. And there's bronchomalacia on the right side. Probably got some ulceration in this area also. So this chap was treated with a rigid bronch, and the removal of this, finally the tract was removed, and he was given a Montgomery stent. You find the right side is quite narrowed compared to the left, it tends to collapse. This is a Montgomery tube which was put, and then after I think 6 months it was removed. So this is to remember that weaning failure is often due to dynamic airway collapse and tracheobronchomalacia as shown here. And you can have a circumferential type, you can have a saber sheath trachea, and this is a dynamic airway, the normal, and when more than 50-60% it's excessive dynamic airway collapse. Same thing shown where the cartilage, if it's involved, you get a saber sheath, this is dynamic airway, and this is the crescentic type, and same thing shown once again. So this is another patient we've had who was referred to me for difficult weaning with an airway tumor at the tip of the trachea, airway tumor, but actually there wasn't. It was just a swollen mucosa. It was right main stem intubation when we received the patient. As you see here, it was missed even on CT. The right main stem is right upper lobe. This is the swollen mucosa, and there's lots of edema there. And a fair amount of dynamic airway collapse after we take the ET tube up. That sometimes contributes to difficulty in weaning, and the moment you decrease CPAP support or CPAP support, the patient doesn't wean well. It takes a long time to wean these patients. And the trachea can work as a stent also. So you have to remember to adjust the vent settings. So when you're bronchoscoping the ICU, if you want to pick up tracheobronchomalacia or extensive dynamic airway collapse, you have to sort of be careful. If you put a lot of PEEP on, then you might miss it. And if you sedate the patient, you might accentuate it. So if you're doing this for an awake patient or a non-intubated patient, be very aware of the level of sedation. You give too much sedation, the airways get even floppier. Mucus plowing, retained secretions, airway edema, laryngeal edema. Sometimes difficult weaning is not because something in the airway, but right in the cords. So sometimes you have to go through the nose and have a look and not forget, just don't finish the bronchoscopy through the trachea, but look above and you may find unanticipated edema. And once in a while you get a rare tracheoesophageal fistula, which is hiding behind the cuff of the trachea tube. So this is a patient with a prolonged ventilation for PCP. She was not immunosuppressed. This is many, many years ago. 6 weeks on the vent. Then she started getting food particles. And if you see here, finally we had to remove the trachea, and we found this small TOF. And she was NPO for a long time. It healed on its own. But so one of the first cases I saw due to prolonged ventilation, maybe the percutaneous trachea, which was done dilational, had caused some damage. This is a patient with airway injury, which I picked up from Dr. Azizi's friend, Hervé Dotau, when we were training. He had a patient who was with a traumatic intubation. This is Marseille, Hervé Dotau's case, 2008. And we saw him doing a rigid bronch on this. He put in a stent, and this sort of deformed mid-trachea due to some sort of traumatic intubation. And the same images. So we've already seen this. The important thing is think of floppy, abrupt web-like stenosis. You've seen all those images, and all these can cause localized wheeze and dyspnea. And you've seen this. I won't go into this. So the therapeutic indications, besides the diagnostic indications, are collapse, retained secretions, atelectasis, as in neuromuscular weakness. Any patient, including COPD, these two groups often have more collapse than secretions. Fiber optic intubation, and to place double lumen tubes, you need a narrow 3 to 4 millimeter scope, which is usually not done these days. Removal of clots and foreign bodies, and more importantly, big clots are difficult to remove in the ICU. You have very time consuming, but if you have cryo, then the whole scenario changes, as has been shown. You may use the bronchoscope for percutaneous tracheostomy. We won't get into this because this has already been dealt with. This is not really in the ICU scenario. Tamponade with balloon, I'll try to get into this if we have some time. Blockers in hemoptysis, putting in spigots as shown by Dr. Azizi, and glue therapy for bleeding, as he alluded to in his talk. A lot of work was done by Bhattacharya from Calcutta, but still not very popular. And the therapeutic BAL can be done in alveolar proteinosis. So there are many indications. The commonest ones are in the next slide. And this is a patient, Nafiz, I think you bronchoscoped this patient with me. This is your image from your talk of a carcinoid patient, and then she had an obstructed major bleeding, and this is what finally came out. When we changed the ET tube, the clot came out in this ET tube, the whole cast of the bronchial, part of the bronchial tree, catastrophic bleeding. So the main indications once again are fiber optic intubations, collapse, balloon tamponade, and in that you have to remember in hemoptysis, you can do a selective main stem intubation, fiber optic guided, to protect the normal lung, which is not bleeding. You may do an ipsilateral balloon tamponade, which I'll show you also, and you might use a univent tube, which is not easily available, but it's got quite a nice design for hemoptysis and to separate the lungs out. So there's something in my book called prophylactic bronchoscopy, where if you go in the ICU, the air entry is extremely poor, but the X-ray shows no collapse. You know, they'll argue with you that why you're scoping, but sometimes you will find the collapse will happen at night when you've gone home, right? At 12 o'clock they'll call you, so you better do the scopy at 6 and go home. In times you might find a lot of secretions which are going to cause a collapse, so that's what I call impending collapse. And some COPD patients who had a lot of secretions, you might do a therapeutic scopy just before you pluck out the tube. It may help. These are rare indications. And after lobectomy, sometimes you get called on day 2, 3, he's not doing well. If you do a scopy, remove the secretions before, it may help to wean the patient after lobectomy. Now, what are these special indications with a mask? And I'll show you the mask, etc. in the workshop. What are the complications? These are standard complications. I don't think we'll get into this right now. The pre-procedure checklist was discussed by the other people. The important thing is clopidogrel coagulation, and creatinine is very important in the ICU. So if the patient's got a high creatinine or on dialysis, he's going to bleed even with simple lavage at times. So be aware of that, especially if he's got multiple factors like low platelets. Also be aware, are you aware what his CO2 level is before you start the bronch? And auscultate, is there severe PAH? Because those patients perhaps you will not consider a transbronchial biopsy. I think all this has been touched by the previous speaker, so I'll just move ahead. But remember, airway bleeding during procedure in ARDS scenario in ICU is going to be very, very troublesome, because as it is, the oxygenation is poor. So that's where you be very careful not to cause bleeding in ARDS if the platelet count is low, even with a lavage, and keep a blocker handy. Now, what are the contraindications? So from the books, the contraindications are anybody with very high flow oxygen with needing FiO2 of 50 to maintain SpO2 of 92. Anything more than that is a contraindication. As I said, there's often a contraindication to do it because later it'll even be worse. FiO2 70%, and when you have high levels of PEEP, high level of FiO2, it's a contraindication. I would call these all relative, because most of the time we are doing it FiO2 1, PEEP 14, and we still get by and nothing really happens. Severe hypercapnia, spasm, once in a while there'll be airway dehiscence, and they'll blame the bronchoscopist for it. It might have been there before, but be aware. And if the patient needs NRV support to maintain SpO2, that's a relative contraindication unless you use it with a mask. These are the other cardiac contraindications. The trolley layout. So important thing is to have a good layout of your trolley and have it sort of organized. And a special mask. So you can use an NRB, besides the normal mask, you can use an NRBM mask. The Oxylog mask has multiple holes near the nares, so you can find easy access on both sides. You can use an NRBM mask with a reservoir bag to get high FiO2, or you can use a NIV mask in certain cases. I use a reservoir catheter, which means double oxygen through the nasal cannula, oxygen through a small Ryle's tube, infant feeding tube in the nose over the epiglottis. So that gives you 5-6 liters. It's a little nice technique, simple in simple places where you can get a good oxygenation in some difficult situations. Sometimes you might want to railroad the ET tube over your bronchoscope if you think it's going to be a difficult intubation, or you may need to intubate as an SOS. Laryngeal mask option is important because sometimes it major secretions, your scope gets blocked, you take it out, unblock it, block it back and forth. So sometimes you feel you might as well intubate or use a laryngeal mask with propofol rather than keep struggling in a non-intubated patient. And obviously discuss your plan with your intensivist who's going to be standing by and helping you, or with your colleague. And awake intubation with minimal sedation. That's why the word awake in airway burns and obese patients. So that's a technique. You have to be slick, but the moment you give sedation, the airway gets floppy and you lose the anatomy. So what is the reservoir catheter? You can supply 5 liters above the epiglottis, and it's quite useful as a second oxygen supply. Need for special mask, good NIV mask was not available, but last 2 or 3 years we've got a nice mask by Pulmocare, and my colleagues Dr. Shamim and Prashant have another Paxi wrist mask. Both have got nice spots which fit snugly on your bronchoscope and make it easy to insert. There's certain tricks in that because sometimes you get stuck at the nose itself. When the platelet count is low, you cannot afford to have any bleeding. So sometimes what you can do is you can remove the mask, pass your scope through the port, do a normal bronch for the first 2 inches in the nose, and then put the mask on. So for the juniors who are getting stuck at the nose, try that technique. It becomes easier. The mask then troubles you less. And always consider in a non-intubated patient whether you want to improve your success with NIV mask, even if he's not an NIV. Application to be considered in all hypoxic patients or respiratory failure patients. The indications are COPD, OSA, OHS, refractory, ARDS type of situations, and severe bronchomalacia, tracheomalacia, and EDAC. Those patients often are helped by this mask with PEEP. So this is the Pneumocare mask which I use, but there are other masks also, but this is quite a good mask. And this is one of my colleagues' recent bronchoscopy, just to show the positioning, but I think the lights are not good. There's an intensivist behind the patient. Patient is lying here, that's the head end. So this is the equipment. So I always tell the operator should also be aware of what is happening besides here, what's happening here. So what is your tidal volume? What is the rhythm like? What is the saturation? And what is your ventilator doing? What are the peak pressures like, etc. So you should have everything put in a way that you can see it and not only be dependent, because you may not have a trained anesthetist or intensivist at the time of you're doing it as an emergency. So this is the Portex swivel connector, which I'm sure most people use, but many years ago when I came to my hospital, they were disconnecting the ventilator for the bronchoscopy. Now there's no need to disconnect the ventilator. You have to have it connected and go through the membrane of this, which opens and closes, and that's how you do it, and that's how the oxygenation will be maintained. I use KY jelly and not lignocaine, which dries up, but KY through the ET tube, otherwise lignocaine on the mucosa, suction traps, etc., 2% lignocaine. The trolley layout, you should have the jellies. You can put a Giddle's airway through the mouth to protect the chap biting your scope. Even if you're on a relaxant, it may wear off. Need for relaxant, when to avoid. This is all for discussion. You may want not to use a relaxant, obviously, even on a ventilated patient if you're trying to look for airway dynamic collapse and in upper airway problems. And level of sedation depends on what you're trying to look for. The ET size is most important, and the scope size. So there should be 2 millimeters plus difference between the scope size and your ET tube size. So if you're having a 8 millimeter or 7.5 tube, which is very common in ICU, a 6 millimeter scope often will cause obstructed ventilation. And if there's crusting, it may not even go down. So then in a lot of large hospitals, you have access to a 4 millimeter scope or even a 5 millimeter look down scope. So to plan it out and make a plan rather than just dive in with any scope available. If you have more than, choose the scope for the size of ET tube or change the ET tube. PEEP issues will be discussed also, controversial. Some people give 0 PEEP. I never give 0 PEEP. I give good amount of PEEP. It becomes easier without any hypoxia. Laryngeal mask and all we've discussed. And always think, though the patient is in ICU, as Dr. Jamal said, you may have to take him to OT, transfer him rather than get stuck and then start arranging rigid. So if you think you may need rigid, then transfer him from ICU to the OT and then do it and plan it accordingly, and just don't dive in just because you're free at that time. Vent settings we'll discuss, and discuss your approach with anesthetist. I tend to use the pressure control mode. It's a little smoother in spite of an obstructed tube. You get better tidal volume, raise the inspiratory pressure levels, and each time you take the scope out, the tidal volume goes up a lot, so decrease the inspiratory pressure at that time. So you can adjust the rate. I normally put a rate of 15, flow about 40, 50, and as I said, the tube, short suction, otherwise you lose PEEP and you get hypoxic, and the PEEP, the books often say go down on PEEP, but I think even 10 PEEP, 14 PEEP, nothing really happens because in such difficult scenarios, you already paralyze the patient once he's intubated. So you use a relaxant. In difficult ventilation, use a relaxant. I would always use some degree of lignocaine because I think there's no harm. It can't do any harm. High PEEP is useful in refractory hypoxemia. It splints the airway, and you may need to titrate the level of PEEP to try to decrease dynamic airway collapse that may help the lavage fluid to return better also. So use relaxant with adequate sedation, prevents coughing, work of breathing, synchrony and hypoxia. Try pressure control, reassess, this is very important, this ET size and fibroscope. Sometimes you have a second scope, you have to borrow it from the anesthetist. Just that 1 millimeter difference makes a lot of difference. Okay, limit the bowel volume. You normally, for a good lavage, you need 100 to 160 ml of fluid, and 20, 30, 40% comes back. But if you're a very hypoxic patient, I go less on the lavage. And sequential lavage is important for hemoptysis or suspected alveolar hemorrhage. The first bit will be less pink and the later return will be more pink. It's very theoretical. 1 in 5 alveolar hemorrhages will do that. The rest is always pink all throughout. But if there's pink fluid on lavage and gets less pink, that's probably a coagulopathy or mucosal suction trauma, and don't confuse that with alveolar hemorrhage. These are various levels. 10 to the power of 4 is the important cutoff number for a significant infection, not an antibiotic. And as I said, all these things I've now discussed. So case selection will vary between different pulmonologists with varying levels of experience and expertise and bronchoscopists. The relative contraindications may be the indication. Importance for all ICUs who are run by non-chest people to involve the pulmonologist early in respiratory failure. And even in mild hemoptysis, you should call them, because don't only call your intensivist when he's got massive hemoptysis, but even mild, so you can plan out things a little better. So are we prepared for the diagnostic and therapeutic approach? Few slides on this to show we have to prepare in terms of equipment. You just can't just dive in without any equipment. And biopsy of the failing lung, once again, you have to plan it out and have a blocker sometimes. The timing will vary depending on the course of illness. As I said, indications will vary with your skill, and what is literature is very scant on this issue of case selection in ARDS and in a failing lung. There's not much work done on this, at least in a controlled manner. So this is a lady I had many years ago, 25 years, severe ARDS, 14 PEEP, small tidal volumes, plateau pressures running at 35. On 80% oxygen, she's only 88. And difficult ventilation, already 10 days on ventilator, no diagnosis, no germs coming up on bowel, on ET secretions. And for some reason, I think we were suspecting this rare thing of vasculitis and alveolar hemorrhage. So you have to ask yourself, will FOB influence the treatment? In this patient, we thought, is it going to be BAL or TPLB, or do BAL? No answer, do TPLB 2 days later, or don't do, she's too sick. So all this has to be discussed with the family, with your intensivist, with your colleagues. But you have to go through this thing and not just do any one of this. You have to plan it out. And you can use a narrow pediatric scope, which makes it much easier to do BAL in these very sick patients. 4 millimeter, 3 millimeter, you can get a good yield still. So this patient finally did have a TPLB, but I sweated and she bled pretty badly. And the answer came back as there's no vasculitis, no TB, no nothing. But we didn't get a good answer. But anyway, she had it, but she didn't crash at least. So hemoptysis in ICU, to wind up the talk with hemoptysis. So you have to remember, as Dr. Jamal said, that bronchoscopy induces bleeding. So half or more than half of the bleeding you're going to see is what you have caused rather than what the patient came with if you start getting aggressive. So are we flexible in our approach? So in a hemoptysis patient, in your mind, are you flexible with what you're going to do? So you may want to do a flexible, but you have to be mentally prepared. Have you arranged the rigid scope? So this is something I saw on a poster in hemoptysis. Well, this is an advertisement in Japanese somewhere in a congress, but think flexible and do rigid. That's what we've been taught in hemoptysis, do a rigid. But I would say we think flexible and do creative, as said here. So think of new devices like the spigot, like glue, or like blockers, and old-fashioned selective mainstem intubation. So don't forget this. I've done this once. During a rigid, the patient bled so badly, couldn't see anything, had to come out, and we had to put this in, and this is what saved the patient, intubating with a 7-8 number ET tube with a fiber optic inside and placing it in the so-called non-bleeding lung. Let this bleed, but this normally stops. And this is very nicely described in 2003. But this selective mainstem intubation you should be aware of this concept. And then put the dependent lung down. You can be creative by putting glue, which is from India. Bhattacharya did a lot of work, but it's sort of not so popular now. The free tag balloon, which Dr. Azizi has shown, is a unique balloon, but is not not available anymore. German balloon, which is a Fogarty, which actually gets disconnected. So you scope the patient, put the balloon down, railroad the Fogarty, the scope out, and then reconnect it. But right now, it's not being made. So you have to use the old-fashioned Fogarty. These are the spigots for hemoptysis, which can be used, but again, not often used. This is the article by Dutau on this. So the free tag balloon is not being made. The resector balloon is used for deobstruction, but can be used to block. Fogarty is the most commonly used catheter. The CRE balloon catheters can be used also for hemoptysis and blockers. So this is the Turkish catheter, which you inflate, deflate, and actually crush tumors and dampen out bleeding of various sizes. This is the portex-fuel connector through which your bronchoscope goes. This is the multi-port MPA, multi-port adapter by Arndt. Very nice, through which the scope goes, the ventilation goes, and your Fogarty blocker can go down. Problem is, it still get narrow at this point. So this is the article on the Arndt blocker. Very nice blocker, little expensive, and hence not used much in India, but I really like it. And it's got a nice big balloon, and we'll see it in the workshop. And for the reference guide, remember the problem with this Arndt blocker is that if it goes through the ET tube, then you need a 4 millimeter. You need a pediatric or 4 millimeter scope for this. And if you have a larger scope, it'll get blocked because the scope, the 4 millimeter and 2 millimeter is 6, so you need enough space for both these tubes inside. So that's why the scope has to be 4 millimeters. Otherwise, if you don't have, you have to put it outside. You have to not intubate the patient and then do the bronchoscopy. And then your various balloon sizes, etc. So this we can discuss later. This is how you snare it, 4 millimeter scope. This is the wire at the tip which you have to snare, and then your assistant pulls a wire from the back of this thing, and it clings onto this, and then it goes down with or without intubation. Keep in mind, it should be a large tube for intubation and a small bronchoscope. As is shown here, this is the balloon, and it's probably one of the best blockers. So for other techniques, the Arndt blocker is pass the Arndt blocker or the Fogarty outside the ET using laryngoscopic. So various techniques. Then pass a 6 millimeter scope through the ET tube via the portex connector. The small Fogarty can pass inside the working channel for segmental tamponade. The larger Fogarty has to be used outside the ET tube. The size of Fogarty can be 614, 514, 714. 14 is the diameter of the balloon, and 6 is the French of the tube. So normally we use 5 and 6, and you put various amounts of air inside. Nice article, again, Dr. Azizi mentioned about DLT. I agree, and this article really puts it in black and white, why we don't use a DLT. So Santo, very old article, 2002. So earlier we'd always been taught DLT is used. I think the only reason you use DLT is for this pulmonary alveolar proteinosis, lavage, etc. But this nice article on hemoptysis, all aspects, and it has nothing to add. In a bad bleeder, you'll not get the tube in place. You have to use fiber optic in sort of positioning. Your scope gets blocked. This gets blocked. There's no time. So there's no role. So in place of that, I think you can try with a univent tube, and I'll show it in the meeting. And the univent tube is quite a unique tube. Again, not easily available. The last time we used it, I think on a bleeder, problem is our scope got blocked. So we didn't have the right size because you need a wide tube or you need a 4 millimeter scope to go down. And this scope can help to place it in the left above the carina. And this blocker goes, this blocker goes alongside a channel outside the tube, and this blocker then goes down into the bleeding lung. So selective intubation of the bleeding side, and you can scope and look at this side. So this is quite a nice thing to have if you get into bleeding, or perhaps if you want to biopsy something which is going to bleed, you could, if you have a narrow scope, you could go down, take a biopsy, and then blow this up also. So it's a different concept of intubating this side or this side, depending on what you're planning to do and what equipment you have, but not easily available. So in massive hemoptysis, remember, you have to put the bleeding side down and consider this always, this option. So in summary, as I said, the contraindications may be the indication, and always remember to call your pulmonologist early, and all of us, all juniors, seniors, all have to be conversant with ICU bronchoscopy, because you're going to be caught in this situation all the time. Timing will vary, indications vary, skill and experience will only comes with keep practicing, and it is very, very subjective. And you need good training, a methodical and a flexible approach. Think of the patient, the situation, the ventilation, what you're trying to achieve. Be well prepared with your ancillary equipment and the various tubes and bronchoscope sizes. Are we well prepared in terms of equipment and your training? There are 5 cases, I don't have time, where I was not so well prepared. These 3 died on the spot. This one had a clot which came out with the ET tube, and we had to put a yanker and chuck out the whole clot. And I think there's no time to get into the cases, but these are cases which will always be in my mind, which 3 or 4 deaths, 1 near death. The journey is interesting. You never know what you may see around the corner. Thank you for your time.
Thanks, sir, for sharing your experiences. The house is now open for any question and answers. Yes.
Thank you, Dr. Ajay, for that very nice talk. Now, for me, I always want to do bronchoscopy in ICU, but I'm always, most of the time I'm prevented from doing bronchoscopy in ICU on a ventilated patient because I'm told the ventilator settings are too high. How can you help me?
So I'll tell you my take on that. So one is that the settings are high. So one is the tidal volume will drop. So either you use a smaller fiberscope, say if you have access to a 4 millimeter, then you'll find your ventilation will not change that much. If there's 2 or 3 millimeters more, you use a relaxant, and you use a relaxant. So even the patient is apneic for those 10, 20, 30 seconds, there's no big deal as far as I'm concerned. If the patient is apneic, if you use sufficient PEEP, you'll often find in these very bad ARDS patients, they've hardly dropped their saturation more than 3-4 points. So it's the difficult patient is the one who's not intubated, who's on the threshold of intubation, where you still need a diagnosis before it gets really worse. They're the ones who dip, and they often dip even after the BAL. 2 hours later, you'll find that, now the anesthetist wants to intubate them because they got worse after the bronchoscopy. But the ones on the ventilator, fine, the tidal volume from 300-400 drops to 100, there's no problem as far as I'm concerned.
So you will still do bronchoscopy in patient with high ventilator settings?
Yes, and
I need advice from my intensivist, and normally they will tell me not for bronchoscopy.
They will not allow me. They will also tell the patient's attendants that he's not fit. So now I have to, besides convincing the intensivist, you have to convince the attendants that that it is required. And simplest thing is to walk away. Okay, I don't do it. But at least from my experience, I can say I hardly have a single case where I think I should not have done a bronchoscopy with a PEEP of 10 and 15, FiO201. Nothing happens to these patients. Their acid is so sick. Their acid is getting suction by the nurse, etc., out of time and again. So they don't crash. It's multiple things. If the BP is very low, okay, then they'll blame the bronchoscopy for the crash. So those ones I get little, if they're very high NORAD. But otherwise, you get good lavages in these patients, especially alveolar hemorrhage scenarios, etc., which can be totally missed. Patient with ARDS, fluffy shadows, no blood coming out. You get a surprise when you go in, and the whole diagnosis will change to vasculitis or something. These are rare, but I think it's worthwhile doing. That is, I think Dr. Nafiz may have seen many of our cases. Dr. Prashant, we worked with
NIV has come in a big way now.
Yeah.
And this technique, when we railroad the ETD over that, because sometimes the history is quite forthcoming. For example, old age, 60-year-old male who went for a natural therapy, and we are on just whether to give him steroids or not. So even if he earns his intubation, anyway he would be intubated. But if we are able to do on NIV, then that could help. And we all know VAP in India is a very bad. CRE is so rampant here. Dr. Damija must be encountering it on daily basis. So we can go for once and we can prognosticate the patient attendant also. Anyway, he is going to earn. And if we can perform NIV, bronchoscopy on NIV, then it can be good for the patient also. Once in a blue moon, we can say to it that the patient doesn't go over the ventilator.
I will have to ask my intensivist to WhatsApp you whenever if I have a case. in ICU for bronchoscopy. I need you to convince my intensivist. Thank you very much.
Thanks for the lovely talk.
Very good lecture, sir. What is your take on doing bronchoscopy in H1N1 ARDS patients? Because nowadays I'm seeing a lot of culture positive aspergillus. Presentation was a PCR positive for H1N1. So
Right.
how often do you do bronchoscopies in these patients?
So we have in our hospital a fair amount because we are also an ECMO center. So we have in our respiratory ICU, the intensivist is trained in ECMO. So we started this program since 4 or 5 years. So the problem we have in ECMO patients is they survive the first illness, then they get nosocomial pneumonia on day 10 and 12 and 18 when they're coming off ECMO. And we often scope all these patients on ECMO also because they got a lot of blood clots inside from the circuit. So the question you asked is how often do you get aspergillus? We do it I say once in a while. Even on ET secretions we've had aspergillus in some of these patients. But we often do it not only for aspergillus, for picking up or proving does he have stenotrophomonas, some odd bug, or once in a while you get meningosepticum, some really rare bugs where you need a slightly different antibiotic. And so there's no problem with or without ECMO. I think most of these patients can be scoped. Especially if you have a narrow scope, then there's no problem at all. The problem is when you have a 7-number ET tube and a 5 or 6 number bronchoscope. But it's like you can have the patient apneic, go and do something for 10-15 minutes or 10-15 seconds and come out, and then ventilate again, and then do it again and again. So I don't think there's no problem. It's just because the anesthetist is looking at numbers. He's just used to the OT scenario. So that's his mindset.
Even patients who are not intubated, still the X-ray is getting bad. Patients improved for the H1N1, then they back in the room. Again, we do bronch after 7-8 days. They are still getting aspergillus infections.
This has been described. I don't have that much experience, but David Denning from Manchester who's got a lovely site, aspergillus.org. At the ERS Congress just I think last year, he had a nice talk. He said it's one of the commonest infections now after this viral infection they're picking up. So everybody should be aware. And we've had a few cases, but and once in a while this aspergillus is like a red herring also. It's they say it may be a contaminant. I don't know, but often when it's really there in a leukemia, you get aspergillus. The 1 or 2 lavages are negative. The third one comes positive. So it's a difficult thing to treat, diagnose and also treat.
Thank you.
Thanks. Let's now conclude this session and move to the next session.